In progress.
Oh, hello. Very, very nice to see you. Happy Thursday. Today, I get to share the stage with somebody who's going to be officially a colleague in a month, at least in my standards. The truth is that many of you are probably, statistically speaking, not yet attending. That is because for most people, by the time they are forging their identity, their interests have evolved beyond the core procedure of diagnosis, and they become experts in uh, different aspects of medicine rather than the core feature of our initial training, which is what is happening to this person. But a small number of people, and myself included, retain that original passion and interest for the first thing you learn in medical school, which is what is this disease and how do we diagnose it? And so it's always such a treat for me to meet people who are much further along in their path today, an incoming chief resident who still maintains that vigor and passion for the love of diagnosis. And yes, today I get to go discuss with my friend and colleague. Get used to that term, Jerome. Colleague, who is an incoming chief resident who is about to, I don't know if your graduation timeline is similar to ours, but graduating anytime soon. It's been a treat to have Jerome as part of the CP Solvers family. If you wanted to remind yourself when he made an impact in the space, he exploded onto the scene with one of the most incredible cases of lower extremity edema and proteinuria. Not just nephrotic syndrome, it was nephrotic syndrome and. And so here we are, hopefully giving you an equally challenging case today, but I'll hand the mic to you, Jerome, to say hi before we introduce everybody else.
Yeah, thank you, Robert, for such a warm introduction. It's been a pleasure being a part of this space, learning from so many different people from such different environments, and looking forward to the case today, looking forward to being in the hot seat for discussion. And hopefully Lyra takes it easy on me today, but I'm sure she won't.
A very timely introduction to our case presenter, Lyra. We're going to hop to the other side of the globe for a moment and give a warm welcome to Johan, who just made it into Baltimore for an important part of his career. Johan, you want to update people on where you're at and what's new?
Hi everyone. So really happy to be here today. So I just moved to Baltimore. I'm about to start my residency here at Sinai Hospital, and I'm really excited to scribe on this hopefully amazing case.
Yeah, it's so cool to see you. You're Johan, like now you can use the words incoming intern, which is so cool. I know you worked very, very hard for it, and it's happy to see it come to physical reality now. It's not yet physical reality for Manahel, but she's on her way. Manahel, do you want to say hi?
Hello everyone, I am Minahil. I am Chief from Pakistan and soon coming to US for my residency. And I'm very excited for Lyra's case today.
A small number of days, and you too shall be on this side of the world. Lyra, I know your hopes and dreams are very, very similar. I know they'll inevitably become reality, but I hand the mic to you to maybe tell us what's new in your life this week and to jump into your case.
Yeah, hi everyone. My name is Lira. I'm a final year medical student from Russia. And what's new? I have some free time actually, so I'm enjoying it.
What are you doing with it?
Nothing.
Uh,
That's the best thing.
just what, sorry?
That's the best thing, doing nothing.
Yeah, I see. Yes, the beauty of diastole. Tell me about it. That's absolutely wonderful. How's your cat?
Oh, he isn't used to me being home a lot, so he screams at me so that I get out.
That's so good. Okay. Wow. I think doing nothing doesn't seem as calming and relaxing as it initially seemed, but I'm sure I'm sure we'll get more and more updates about human and cat dynamics over the course of your time in VMR. All right, we're ready whenever you are.
Yeah, just a small remark. This is actually a case that Alec was kind enough to share it with me. So all thanks to Alec for making this session happen. Yeah, just wait for the whiteboard to come up. Yeah. So this is a case about a 58-year-old female that was actually brought in by her daughter due to a few months of progressive fatigue, weakness, and confusion. And they were prominent so much that they eventually caused a rapid decline in the patient's functional status. And on baseline, she was previously completely independent, but by the time of presentation, she has lost all the ability to do her usual activities of daily living. So due to prominent confusion, most of the history was obtained from the daughter. And you see that on review systems, they report poor oral intake, and they also notice some subjective fevers, chills, and approximately 50 pounds or 22 kilos of unintentional weight loss over the past few months. But otherwise, review of systems during preceding weeks was completely negative, so no cough or shortness of breath, no chest pain, no nausea, vomiting, or changes in bowel habits, and also no dysuria were noted. And that's it for the first aliquot.
Wow. Oh my gosh. What an explosive start. Hey, Jerome, you're a very, very experienced resident, soon to be attending. I'm curious if you wouldn't mind shedding light on what it is that you got. Basically, this is an opportunity to shed with people who are junior in their journey. You just got a whopping data.
Mhm.
I'm curious if you wouldn't mind elaborating on where your mind is inclined to start. Where is the sequence beginning before you kind of just spew poetry at us?
Yeah, absolutely. So whenever I'm meeting someone in the ED, especially for what seems to be a subacute progressive phenomenon to the point where they're like they've lost all function in their ADLs, I always want to make sure, that I need to address all the acute things whenever I'm meeting them in the emergency room.
Yeah.
And so it seems like, she's kind of been going on a downward decline, and now she's had an acute drop in her functionality. So my immediate things is to one, is this patient stable? Kind of where is she? Is she able to communicate with me to give me any of this history? And then other things is that the fact that her daughter is just giving all the history is something that's very alarming. So my immediate thing is to one, is this patient stable, and where does this patient need to go? But the background history, kind of what Lyra's already shared, is that this seems to be a more systemic issue, and I can't quite localize where it is. But ultimately, the acute decline is what I would address immediately, trying to find all of the emergent things that need to be recognized quickly in order to triage her appropriately. So that's where my mind goes immediately. But I'm happy to shed light on kind of what I think about her subacute progressive
Yeah. Yes.
syndrome too.
Take it. Thank you for saying that so clearly. Yeah, take it away. What you got next?
Yeah, yeah. So ultimately, you have a middle-aged female. We don't know her background medical history, but we do know that she was at one point functionally dependent. And now over this course of time, now she has progressively been able to lose her ADLs to the point now where she is completely dependent on her daughter for all of her activities of daily living. So for me, this could localize in a number of places, but whenever I hear about weakness that has, some neurologic component to it, my mind goes to, is this a primary neurologic phenomenon? Or is this something that's more systemic that is now manifesting in a neurologic way? And so ultimately, I know the exam and the background history will kind of shed some more light on that, but it seems to be an inflammatory syndrome with the weight loss, with the fevers, with the progressive, decline in functionality. All of those things kind of ring true for a chronic disease that is now, becoming more acute.
Uh,
I'll defer to you.
That's absolutely superb. I couldn't agree more with you. I think that there's a beautiful symmetry really that's happening here where the brain is down and the body is down in a very symmetric way, and we haven't found a focus of activity that breaks that symmetry. And I think that's the journey that we're probably going to be on, is to say, do we find an area of asymmetry? And an example of that would be that we find on X-ray a large focal lung mass. And that area of asymmetry allows us to see how this disease has caused widespread devastation. Ultimately, that's what I'm tracking, is there asymmetry or not? Because asymmetry will likely represent the home base of this disease process. And it may be that this process does not have a home base and the patient has a process affecting her at the molecular level, say, for example, that she has severe hypercalcemia from a ingestion or granulomatous disease process. So I'm right there with you. I think you outlined it so well. Brain is down, system is down. How we connect those two things is multi-pronged and multifunctional. And I think the only thing that we can make progress on very quickly at the level of the exam is to see if there is anything asymmetric neurologically, which would really up the ante, or asymmetric anywhere else, focal crackles, right upper quadrant distension, a large skin lesion, so on and so forth. So I'm really curious to see that. And then the other element, I think, which is becoming increasingly important to me, is to not just focus on what the patient has, which is the most of our conversations on VMR, is like, what is this disease right now? But I think a powerful insight into what this disease is also in parallel asking, why did this person get this disease? And if we later learn that she has widespread lung cancer, I'm harping on that as an example, hearing about her smoking history will give us a lot of insight into the why. So right now, the what is mysterious. And of course, if the what is mysterious, the why is going to be mysterious too, by definition. But as we get more and more clarity on the what, usually hectic systemic syndromes, you get a lot of insight by asking why. And yesterday we had an academy session with our newest member, Sakith, who shared with us a case of HLH. And it became more and more clear that the why was that he was in a TB endemic region, and that figuring that out was fundamental to the workup in that case. So, beautiful job. Let's uh, let's try to outline that connection between brain and system, and then separate to that, look for asymmetry and keep track of the why. Those things I think will help us shed light a lot on this case. All right, Lyra, what do you have next?
So, Jerome, you were curious about the history and exam, so ask and you shall receive. As for the rest of the history, the patient actually had no known past medical history prior to about 4 months ago when she started having some abdominal pain. Along with the daughter, they went to a few different clinics, during which time she received a course of antibiotics for presumptive salmonella infection, but it actually was not unclear how this diagnosis was made. And the antibiotics, unfortunately, did not help her symptoms resolution. She also got some urine and blood work done, and apparently it was all normal throughout this time and as recently as 1 month prior to presentation. For the rest of the history, the patient doesn't take any medications on a regular basis. She has also prolonged history of heavy tobacco use. Originally, she is from Mexico, but moved to the US 1 year prior to presentation, and otherwise she has no relevant family history or past surgical history. On physical exam, she was actually febrile on admission with a temperature of 38.3 degrees Celsius. Her blood pressure was also noticeably low at the level of 94/65, with heart rate of 114. Respiratory rate was 23, with SpO2 of 98 on 2 liters oxygen via nasal cannula, and her oxygenation was stable throughout. On cardiovascular exam, you see that there is no obvious jugular venous distension. The patient is currently tachycardic with regular rate and rhythm, but you're not able to hear any additional murmurs, gallops, or raps. On pulmonary exam, she is also tachypneic, but lungs are actually clear to auscultation bilaterally without any crackles or wheezing. Her abdomen is soft, non-tender, although it's mildly distended with palpable hepatomegaly. On neuro exam, you will able to see that she is lethargic. She opens her eyes to name, but is not able to respond to any questions, and is oriented only to self. But you're not able to appreciate any obvious focal neurological deficits. On HENT exam, you see that the patient has dry mucous membranes, and you also spot enlarged palatine tonsils, along with palpable cervical lymphadenopathy. Otherwise, on general exam, her extremities are warm and well perfused without any evidence of peripheral edema. There is also some mild jaundice appreciated, and overall patient is in acute distress, and she looks really pale, weakened, and cachectic. And I will pause here.
Jerome doesn't look like she's like actually seen. This is such a colorful presentation. Lyra, you're bringing the patient to life. I'm so sorry. I got a message from my team and when you first started the Alquat. You mentioned something about salmonella. Do you mind just reminding me real quick?
Yeah, so she started having some abdominal pain 4 months
I
ago.
see. I see.
They went to clinics and she received a diagnosis of salmonella infection, but actually no confirmation for that diagnosis with no effect from antibiotic course.
Understood. Jerome, I bought you some time there. What do you think?
Yeah, so I still think her background history is actually very interesting, but the more present issue is stabilizing the patient. She's febrile, she's hypotensive, she has sinus tachycardia with acute hypoxic respiratory failure. She's only alert times one with reportedly, a normal functional baseline several months ago with abdominal distension, scleral icterus, and she's warm and well perfused distally, but it seems like there's no focal neurodeficits. So ultimately her exam screams sepsis syndrome to me initially, and stabilizing her is probably the more acute thing. But the background kind of what I was thinking about is, what, 58-year-old female comes to, medical attention, in her 60s ultimately, and then hasn't seen a doctor before. And she's coming from an endemic region with hepatomegaly and jaundice. So those are the things from the background that's kind of ringing in my head that we'll need to explore fully once we stabilize the patient. But ultimately, this exam is very explosive, and I would just love to see what her, biochemical profile actually looks like. But stabilization is the next step, and those are the things that need to be done more urgently. But just realizing that this is a chronic process with a more acute manifestation, and it seems like we have, the disease localizes to possibly the GI tract, potentially, in the right quadrant in the liver, some hepatobiliary pathology. Is how
Yeah.
I'm shaping things.
I love it. I really appreciate your being authentic to the fact that you're first focusing on stabilizing her and then focusing on nerding out about what's going on. And I think that's so true. And if she meets sepsis criteria, you probably would cover her with broad spectrum antibiotics. And whenever you have fever, jaundice, and tachycardia, cholangitis until proven otherwise. Uh, and I imagine that we're not going to harp on that aspect too much because, gosh, the amount of thinking that we'll have to do in this space, which is protected for that, is massive. So now that you take a breather, you put in all the orders for fluids, antibiotics, and you step away and you're putting your note together. What juice can you get out of this information from a diagnostic perspective?
Yeah, so I mean, really, my whole thing is kind of looking at her abdominal distension and the hepatomegaly is probably where my eye goes the most, but recognizing that she has acute altered sensorium too, so trying to make sure that we do a more exhaustive neuro exam. Like, she doesn't have anything focal, but there some sort of micro neurologic finding that we're missing, like some subtle tremor, some asterixis, those kind of things. But ultimately, someone who's presenting with this degree of altered mental status with what seems to be a hepatobiliary pathology, are we going to call this acute liver injury versus acute liver failure, even though we haven't seen the biochemical profile? And is there some sort of endogenous substance that's leading to her change in sensorium? Is the other portion of her presentation that I'm actually calculating as well.
Yeah. Yeah, 100%. I couldn't agree with you more. I think that's your analysis with the jaundice and hepatomegaly really localizes the disease to the liver itself. And so you're wondering what's happening to the liver itself. And I think the fact that the liver is big and the fact that there's lymph nodes involved in the cervical chain gives you the sense that the probability that you have a space occupying process in the liver, meaning that the imaging is going to be positive, is pretty high. You can feel the liver, you can feel the lymph nodes. So odds are the radiologist is going to see something in the liver itself. Of course, that may not necessarily be true, but I think that's the hypothesis that I would be entering, is this is probably a space occupying process. And when you have a space occupying process anywhere and you have somebody who's confused, you worry that their confusion also reflects a space occupying process. So if I were seeing this patient in the ER, I think that the patient could have a molecular reason to be confused, like hyperammonemia. But I think the fact that she has concern for space occupation in her liver would have me pursue with vigor that hypothesis in the brain. And here's how it changes subtly. So most of the time, this patient's going to get basic labs, going to get cross-sectional imaging of her abdomen, maybe her chest because she's hypoxemic, and maybe get a non-contrast CT scan of her head. Um, and then followed by an MRI. But this is the time where if you use your CT with contrast for the brain wisely, with that same 2 seconds in the scanner, you can make a lot of progress. So instead of getting her a regular old non-con, what you could do is to do a CT brain with contrast. It's different than a CTA because the CTA of the brain prioritizes the arterial phase. But if you do the parenchymal phase of a CT with contrast, you'll be able to delineate with much more clarity whether she has intracranial masses that enhance or not. Much better than a non-con CT. Not even close to an MRI, but way, way, way better. So the only thing that changes on my analysis thus far is the hypothesis of space occupation peripherally mandates a search for it cranially, ultimately with an MRI if needed. But you can make a lot of progress with just adding a little bit of dye to the brain in addition to the belly. Now that may not happen in busy emergency rooms when you don't have time to sit and dissect the kind of thinking that we're doing now. You may skip over that, but I just want to emphasize the value out of that. Awesome. All right, Lyra, mic to you. What do you have next?
Yeah, so many great barrels. So with 3 out of 4 source criteria and 3 out of 3 QSOFA criteria, due to concern for actually septic shock with unclear source for now, she was admitted to the MICU and started on IV fluids, low-dose pressors, as well as brought antibiotics, including vancomycin, ceftriaxone, and metronidazole. We also ordered blood cultures, and currently they are pending. So for some basic labs, her CBC showed white blood cell count of 10 with 90% neutrophilic predominance in differential. She was also quite anemic. Her hemoglobin was 6.8 with unknown baseline and MCV of 89.9. Her platelets were also on the lower side of normal, so 145. Metabolic panel showed glucose of 71, sodium of 134, potassium of 4.5, chloride of 100, calcium of 8.9, phosphorus of 3.6, and magnesium of 2.2, and all those lab markers were normal. For kidney function, her BUN was 17 with creatinine of 0.6, which was actually borderline low. For liver panel, her AST was mildly elevated at 42, with her ALT normal at the level of 12. Her alkaline phosphatase was elevated at 301. Total bilirubin was also elevated at 3.8 with direct bilirubin measuring 2.3. Total protein was 4.8 with albumin of 1.8, and both those parameters were low. ESR was elevated at the level of 66. VBGs were also ordered, and pH was 7.3 with PCO2 of 27.8 and bicarb of 16.1. Lactate level was also ordered and showed that it was quite elevated at the level of 3.9. Also, some basic instrumental workup was done. ECG showed sinus tachycardia and otherwise was normal without any concerning ST or T changes. And chest X-ray was also unremarkable with one exception for subtle reticulonodular opacities over the bilateral lower lung bases. And I will pause here.
Do you want some more data, Jerome?
No, this is absolutely enough to chew on for sure. This is an awesome presentation, Lyra. I know that some of the data will start to pop into the whiteboard, but immediately where my mind went to is looking at her hepatobiliary lab essentially. So she has a predominantly cholestatic pattern on her liver enzymes. She has the elevated total bilirubin with a direct predominance. So that kind of singles me into like this is, the biliary tree is actually at the forefront of this case essentially. And so kind of where my mind went to next was that her INR is greater than 1.9 and she is forwardly encephalopathic. So ultimately, one could actually call this acute liver failure and not necessarily acute liver injury because she meets that criteria with change in mentation and INR greater than 1.5. And so ultimately that's where my mind essentially goes. And then now I'm thinking about ascending cholangitis as being one of the causes for her sepsis syndrome, even though the rest of, we still need to examine the rest of the labs, but that's what jumped out to me initially. And so ultimately, the other thing that I thought about too was like if you're looking at her CBC, you see that there's a neutrophil predominant white count, which is not surprising in the setting of possible ascending cholangitis. They have anemia, which is a normocytic anemia, and then they have some low normal platelets. And so ultimately, this can be a profile that you see very commonly in someone who has sepsis, but you always have to think about, does she have some baseline cytopenias that could be explained by what we've seen with her basically a subacute kind of decline over the last few months. And so ultimately what diagnosis wise, what I started to think about is she's profoundly inflamed, evidenced by her LDH being 800, her ferritin being greater than 700, her CRP is elevated. So all those things make me think about, is this what is actually invading into the biliary tree? And where my mind goes for a cholangitic pattern is this an obstructive disease from a stone? Is this something that's infiltrative disease like sarcoid, TB, some other sorted GI tract or some GI microorganisms that are kind of ascending up into the biliary tree. So does she have some pre-existing stenosis that could be, she had some underlying PSC, some primary sclerosing cholangitis, or primary biliary cholangitis, any one of those diseases. So ultimately, whenever I see that cholestatic pattern, I think about infiltrative diseases, think about the common things, whether it's from a stone, from sludge. And then I also think about anything ascending up from the GI tract, which is more times than not enteric organisms, gram negatives, which I think she's on appropriate antibiotic coverage for that. So, to kind of summarize those things, she's profoundly inflamed. She has a cholestatic liver injury. You really could call it acute liver failure, really, just based on her INR and her hermentation kind of non-existent at this point. And so just thinking about, that's likely where we need to, explore a lot more of our diagnostic energy is where my mind is for this aliquot Rabih. I don't know if you agree.
Of course, I think absolutely superb. I mean, I think most of your diagnostic analysis was on the term cholestatic disease, and I'm right there with you. I think it's fascinating how underwhelming her AST and ALT are. And so you have a disease primarily of the biliary duct cells. And I think the question that we're going to try to make progress on, Jerome, is to say, uh, which biliary duct cells? The ones outside the liver, i.e., called extrahepatic biliary disease, which have nothing next to them and have no other purpose but to excrete bilirubin. And so an example of that kind of disease would be a pancreatic cancer compressing on those things. And the patient usually just has painless jaundice without anything else going on. They may have some abdominal pain, they may have weight loss, but they don't tend to have confusion, fevers, chills, unless they get cholangitis. That's possible. The other place that you can have biliary disease is in the microscopic biliary duct cells that course within the liver itself. And the liver itself is a much more systemically communicative organ, which talks with the rest of the body in a much more streamlined way than the extrahepatic biliary tree. So if you have somebody with a primary cholestatic disease who has prominent systemic signature, the probability of it being in the liver itself is very, very high. And so if you're trying to make an educated guess between is the extrahepatic tree involved or is it the intrahepatic, the presence of systemic symptoms often correlates with the liver being involved itself. And when the liver is involved itself, the question is, do you have a mass-forming liver process? Or do you have diffuse subradiological infiltration? And I think that's the only way to answer that is through a CT scan. And I think it's really hard to distinguish between those two things at this time, quite honestly. And so the thing that I'm really hoping for that will give this case a tremendous amount of momentum is the imaging. And one interesting element of it one interesting independent element is the VBG. Lyra, I don't think it's on the whiteboard. Do you mind just sharing the VBG with us one more time?
Yeah, absolutely. So pH was 7.3, PCO2 was 27.8, bicarb 16.1, a lactate of 3.9.
Gotcha. Yeah, the lactic here is the driver of that VBG, and you might map that on to the patient's liver injury. But Jerome, I think the question of does this patient have a hepatic encephalopathy is an interesting one. Because she does have a coagulopathy and she does have hyperbilirubinemia. Both those things are evidence of hepatic synthetic function. And so the question is the liver also not clearing enough toxins, causing her to be confused? And hepatic encephalopathy strictly requires either the diagnosis of cirrhosis, which she does not appear to have at this time based on the lack of ascites and hyperestrogenism, or the evidence of acute severe hepatocellular disease. And her AST and ALT are incompatible with that. So strictly speaking, even though she has liver disease, a high INR, she doesn't seem to have the two kinds of liver disease associated with a lactulose responsive encephalopathy. And it goes to show you that you have to be careful about rendering that diagnosis because it may allow you to be slower to the draw to pursue the hypothesis that she has space occupation in both her liver and her brain. So what could this be? She could have metastatic blank in her liver and in her brain. And the reason she's confused is not that her liver is causing a brain problem, but rather that there's a systemic disease affecting both organs simultaneously. And so, because she doesn't have marked acute hepatocellular injury or she doesn't have cirrhosis, I would probably be cautious about ascribing the connection between liver and brain to be an arrow that goes from the liver to the brain. Rather, I think I would be worrying that there is an underlying criminal causing both crimes at the same time. That'd be my default hypothesis. But yeah, let's see what you have in store for us next year.
Yeah, I have next some advanced imaging, but first I'll tell you more about the patient scores. So her blood pressure actually responded well to treatment that was provided to her, and she actually remained normotensive afterwards. But later on, she developed mental status change with progressive agitation and confusion, with ongoing fevers and tachycardia. So some investigation was done, and TSH was normal. Ammonia levels was mildly elevated at the level of 61.3, with upper limit of normal being 53. And her glucose was 48. As for infectious workup, her HIV test was negative. Hepatitis panel also came back negative. And CT, chest, abdomen, pelvis was done, and it showed no evidence of acute chest or abdomen abnormalities, but it revealed hepatosplenomegaly with periportal edema, but no focal hepatic lesions. Gallbladder looked absolutely normal with no gallstones or wall thickening, and no evidence of biliary duct dilation. It also showed diffuse abdominal, pelvic, and thoracic lymphadenopathy, and some locations included bilateral hilar lymphadenopathy, mediastinal and lower cervical nodes, also diffuse retroperitoneal lymphadenopathy, a 2 centimeter portohepatis node, as well as right pelvic, external iliac, and inguinal nodes. It also showed bibasilar atelectasis and a few solid right lung nodules up to 0.7 centimeters in diameter in upper and middle lobes. And it also showed mild anasarca. So due to mental status change, brain MRI was done, which showed no acute abnormality in brain parenchyma or any leptomeningeal disease that would explain this new change in hermentation. But it revealed diffusely heterogeneous bone marrow signal with multiple small enhancing foci that could reflect the myelin filter process. Also, urinalysis was obtained, which showed trace protein, but otherwise was unremarkable, with just one white blood cell for HPF and no bacteria and negative nitrates. Quantiferon gold came back positive, and also LP was done, and CSF was clear appearing and had normal glucose, protein, and white blood cell count with just 0 to 2 RBCs in 2 samples. And I will pause here.
Oh my gosh, what a large amount of very, very helpful data. I think, Jerome, we might have some time for just maybe a 3 or 4 minute breakout room to allow you to share your thoughts with folks and to put them together because this is a lot of information. So why don't we go ahead and do that? And we'll see you all in about 3. All right. Back, everybody. So Jerome, what was the conversation like? Where are you at?
Yeah, I mean, so we initially went through like all the imaging, like what we were considering is this a primary neurologic issue, but it seemed like it was more so a systemic issue, with this diffuse lymphadenopathy within, the inguinal region, it's in the retroperineum, it's in the mediastinum, and then with the positive quantiferon TB. The other thing that we were talking about was just the imaging being negative with like this, hyperintense signal within the marrow, which makes you think that she likely has disseminated TB. And so we ultimately kind of went on the journey from how she presented. She's coming from an endemic region, and it just went through that whole diagnostic progression. But then we were kind of talking about next steps to actually clinch the diagnosis and what other alternative etiologies could be, for someone who's coming from an endemic region, who's at, high risk for like endemic infections as well. So we were talking about those and, how people get exposed to TB, especially with the low grade hypoxia and stuff. So we went through a lot of things, but it was a good discussion that we had in our group.
I love it. Yeah, and where do you think you would go next? What would be your ways to try to make progress on this case?
Yeah, so we actually had that discussion. So we know that TB, the portal of entry is usually through the lungs, and so
Mhm.
she's coming from an endemic region. We don't know the more prominent feature of her case was actually the cholangitic presentation, but if she had some sort of cough and is making sputum, that somehow resurface, getting AFB cultures. We talked about some of the PCR based testing for this. And given her cytopenias, it could be in the setting of sepsis. But if we entertain the thought train of doing a bone marrow biopsy, you can get AFB cultures from that and
Yeah.
start culturing from that region as well. So we talked about all those ways to kind of cinch the diagnosis, but I think that could be logical.
Yeah, I'm right there with you. I think that, you found that this is in fact a space occupying process, and the space it's occupying is diffusely throughout the reticuloendothelial system in the form of lymph nodes and the bone marrow. And going back to her hepatosplenomegaly and her cholestasis, I think you've proven now that she probably has infiltration of that same process into her liver and her spleen. And the area of asymmetry, to go back to that original conversation, seems to be in the lungs where she has these reticulonodular opacities just in her lower lobes. And so you're wondering if that's where the disease launched into her body. And I think you're using the why to help you say that she has extensive residence in a TB endemic area. And that why is helping you prioritize tuberculosis. And I think similar to tuberculosis, the most important granulomatous infection that's present in North and Central America is histoplasmosis. And so in this patient, disseminated histoplasmosis can cause an identical picture. And so in the infectious realm, I'm right there with you. And I think, of course, those two hypotheses would prompt an HIV test. Um, and if it's not an infection, what kinds of diseases do you think, if your entire infectious workup was completely unrevealing, what kinds of non-infectious diseases would you be open to diagnosing in her?
Yeah, so I think from that point, just given her diffuse lymphadenopathy, you would have to entertain the idea of a possible lymphoma, especially with,
Beautiful. Yeah.
the hepatosplenomegaly. But then you have to consider the possibility, does she have some sort of other autoimmune condition or some sort of infiltrative disease, some granulomatous disease? So I
Beautiful.
think you can open up those buckets as well. But if it's not an endemic, mycotic infection, or it's not TB, I would
Yeah.
ultimately entertain the diagnosis that she could have had like an indolent lymphoma
Yeah.
or potentially some sort of other autoimmune or granulomatous disease.
Yeah, excellent. Yeah, I'm right there with you. I think that for me, the highest considerations are always the practical ones that need to be treated first, and TB, histo, HIV is my initial checklist. And then, using the fact that she is a middle-aged woman, being open to the possibility of metastatic breast cancer, which would not be imaged adequately on a CT scan, which misses the tumor within the breast tissue. That's a really important consideration here. As is her fact that she has a heavy smoking history, which would be open her up to the possibility of extensive, widely metastatic lung cancer. You are, I think, spot on to also mention the possibility of a lymphoma. And a lymphoma is something I thought about because we're seeing a little bit of what's called the Warburg effect, where the patient has a lactic acidosis and hypoglycemia is a feature ascribed to the Warburg effect in lymphoma. But the problem with that is that the hypoglycemia and the lactic acidosis have an equally compelling explanation with the fact that her liver is not working good. But I agree with you. I think next steps is to sample the lungs and the marrow, I'd imagine. The lungs with sputa, then maybe with the bronch, and the marrow biopsy, I think, will be very, very telling in this case. What happened, Lyra? What did you all do?
This is such an awesome discussion, and Jerome, I can't believe this is your first discussion. A lot of infectious workup was done due to positivity of clone gold, and TB testing in the form of AFB sputum cultures ×3 with MTB PCR was negative. sputum culture, fungal sputum culture, and PGP-GFA from sputum also were all negative. Multiple sets of blood cultures also returned negative. Cultures and all other infectious workup from CSF also was negative. So for the patient's course, her lactate level initially started to improve with treatment, but over the next few days, along with her worsening mental status, started to increase and peaked at approximately 14. LDH was sent and came back markedly elevated at 500 and continued to rise up to approximately 800. Uric acid and B12 levels were completely normal, but ferritin was severely elevated at 737.8. Bilirubin also continued to rise up to 7, and it continued to be direct predominant. And leukocytosis also increased up to 14. But this is not the only change, and her platelets actually continued to decrease up to 63. And to exclude pseudothrombocytopenia, peripheral blood smear was done, which showed absolutely no evidence of clumping. And besides that, it showed anisopoikilocytosis with occasional schistocytes, macrocytes, elliptocytes, and echinocytes. And red blood cell precursors, including nucleated RBCs, were also identified on the smear. White blood cells are adequate with lymphopenia and neutrophil predominance, with left tube with neutrophilic granulocytic precursors, including occasional metamyelocytes and myelocytes. But no blasts and no atypical lymphoid cells were identified on the smear. They also repeated the imaging, and it revealed no new findings in comparison to the last one. And then a single diagnostic test was done, which will reveal the final diagnosis in the next aliquot.
My mic stopped working. Sorry. I love that term, Lyra. A single diagnostic. Just one. All this work could have just been saved by doing one test before. So beautiful. Jerome, what do you think that test might be?
Um, to be honest, I don't really know, but I
Okay,
guess the
fair
other
enough.
thing, yeah, I really don't know, but it was a lot of extra data that kind of made me think a little bit. But she has, microangiopathy and TMA with like end organ dysfunction at this point. And so I start to think about, is there anything that hasn't been mentioned yet? And I started thinking about like any pathogens that could be invading like the red blood cells and kind of causing some sort of like a other hemolytic process. But I think doing a bone marrow biopsy will probably be the test that's actually going to give us the answer. So I'm thinking at this point, there were no blasts on the smear, but we have, a lot of different cells with different morphology with in the periphery. So me thinking that, this could possibly be some sort of lymphoma is actually what I think would be the most likely, but I could be totally wrong. So I'm gonna have to lean on your expertise, Rami.
No, I mean, I don't have any expertise, honestly, in this domain. I think it's really all about knowing what the next step is. And I think in a disseminated reticuloendothelial disease, there are two high yield steps. Is to extensively sample the lungs for infections that originated there, and that includes bronchoscopy and biopsy, and biopsying the bone marrow. Those are the two most helpful things through and through. And what are you going to find? You're going to find either a granuloma or a lymphoma or a metastatic solid tumor. And distinguishing between those three things is impossible, which is why we even expose the patient to the morbid procedure of a bone marrow biopsy. But the yield of a bone marrow biopsy has just skyrocketed because of the fact that we see there's something in the bone marrow pushing nucleated red blood cells and precursor cells outside of it. So there's something in that marrow, and we will find it. The thing not to get lulled by is to not just do one bone marrow biopsy, because the yield of a bone marrow biopsy in a space occupying process is only 50%. So you might have to repeat it. But there is something in that marrow. And the question is, what is it? And I think your options are disseminated TB. Histo is not a consideration, really, realistically speaking, because the patient is HIV negative. It's very unusual to have disseminated histoplasmosis without HIV. So disseminated TB, metastatic lung cancer, infiltrating the marrow, metastatic breast cancer, or lymphoma. And for me, my educated guess would be lymphoma for the following reason. It is the most notorious cancer to induce what's called the Warburg effect. The Warburg effect is when metastatic cancer hijacks the glycolysis system and disproportionately makes lactate, lowering the glucose. And the fact that this patient has the combination of super high lactate and a low glucose is very, very suggestive of that physiology, which is most well described in lymphoma. Now, it would be hubris to say, I see the Warburg effect, so I will not do the bone marrow biopsy because I know this is lymphoma. Let's treat the patient for lymphoma. Um, that would be malpractice. It's an educated guess. So what would I do? I would call the pathologist and say, hey, I can give you a heads up that clinically it's either going to be granuloma, lymphoma, lung, or breast. That's my guess clinically. And I would lean towards lymphoma because I'm seeing the Warburg effect. What do you see? Not tell me it's lymphoma because I'm an overly confident. That would be my guess. But any thoughts or clarifications or questions about that, Jerome? Before we hear from Lyra about the single test. I love that.
I know. Whenever she said that, I'm like, whoa, that it made me consider my calculus again. But no, I think you outlined that beautifully. Yeah, this can't wait to see the answer.
All right, Lyra, Mike to you.
So this test was inguinal lymph node core biopsy, and it showed negative stains for FB and some fungal stains, but it also showed sheets of typical lymphocytes positive for PAX5, CD20, which are basically B cell markers, also CD10 and BCL6, which are basically cell of origin markers for pathologists. CD5 also was positive, which actually indicates poor prognosis in the diagnosis that I will reveal in a second. And proliferation index was around 90%, which is really, really high and indicates high cell turnover. And they also did the FISH testing, and it revealed both BCL2 and MIC rearrangements. And flow cytometry showed a monoclonal B cell population that is kappa light chain restricted and positive for CD10 and CD5. So all this alphabet translates into the diagnosis of diffuse large B cell lymphoma, which this patient eventually had. So you were right.
If this patient were to have any cancer, it probably is this one, though the morbidity is very, very high. As I mentioned to Jerome, I have to hop off earlier to make it to work on time, but I just have to say that the ability to bring to life this patient's story in the manner that you did, Lyra, was absolutely outstanding. It really is a marker of your clinical skills and confidence, and also just your very engaging persona. It was a real treat to see all that on display today. And Jerome, I think I will be brief and echo what Lyra said about it. Hard to believe that this is your first discussion. I'm glad that it's probably the first of many, many, many. I'm also glad that it's in a space that you are likely to pursue expertise in your career, and it's easy to see that you've already laid the foundation for a very, very prosperous career. That you are on point and accurate and authentic the whole time. I'm curious what reflections you have on the final DX and how it felt to discuss.
Yeah, so it's surreal. I mean, just listening to the podcast, being tuning in with VMR, it's just really surreal to be in this space to discuss a case, especially in an area that I'm actually interested in. And this is a very, very common presentation for lymphoma, but usually I'm just like, it's not going to be something really common. It's going to be a common presentation of something esoteric. So that's you always have to be authentic to the space, but knowing that this is basically triple hit, DLBCL is just one of those diagnoses that I see pretty commonly, especially like where I've trained. And so this was a really, really great case, and so fortunate to be in this position. And thank you for giving me the opportunity to be a part of the clinical problem solvers, and to just learn from everyone. So I really appreciate it. This was a great case.
You're not just part of the CP Solvers, my friend. You're a core ingredient. In fact, you're the host of this meeting now. All power to you. I will have to hop off to make it to work, but I'll hand the mic to Manahil for the teaching points.
Thanks, Rabih. See you soon.
Okay. Thank you, Lira, for bringing this wonderful case and amazing discussions by both of you, Jerome and Rabih. So when patient, like in this case, patient cannot provide the history, so it like often indicates patient's baseline that it can have impaired cognition, delirium, or clinical decline. And we also have to understand like why patient is presenting like this. What's the risk factor behind this? Whether it's the patient age, exposure to any toxins, patient have any comorbidities or any genetics that is causing patients this condition. Then we study about the weakness that can be neurological, whether patient usually presents asymmetric examinational findings versus systemic, where that weakness was symmetric. Here, patient have fever, jaundice, and like tachycardia that usually point towards the cholangitis until proven otherwise. If the patient have other mental status and liver disease, it mostly point to the hepatic encephalopathy, and this AMS is usually due to the hyperammonemia, and INR also reflects the synthetic liver dysfunction, and it is an important marker for the severity of liver injury. Then we have here patient have a cholestatic pattern that has high ALP and bilirubin that was pointing towards the bilirubin pathology. We have to differentiate whether it's extrahepatic, whether patient usually have a painless jaundice versus the condition in intrahepatic, and to find out like whether the mass is in the liver or like an infiltrating mass in the liver is causing this, we will need an imaging. Patient here is like pointing towards the space occupying cells that was located in the reticular endothelial region that involved lymph nodes, bone marrow, and then was infiltrating to the liver and spleen. So like it can be maybe due to infectious causes or non-infectious. In infectious, it can be TB, histo, HIV. Non-infectious, it can be granulomatous disease, lymphoma, and metastatic cancer disease like breast or lung. So to confirm that whether patient have a reticular endothelial disease, we need to investigate two systems, the lung by bronchoscopy and biopsy, and bone marrow biopsy. Then Rabih explained Warburg effect, like cancer cells, what they do, instead of going to the anaerobic metabolism, they go towards the aerobic metabolism, where they don't utilize the oxygen and convert the glucose to lactate, so they can have a rapid energy production that will support their uncontrolled growth. And that's the teaching points. Thank you very much.
Yeah, thank you so much for Manahil for giving such great teaching points. Thank you, Rohan, for scribing. Lyra, thank you so much for such a great case presentation. This was awesomely put together, and thank you, Alec, for the case as well. You know, I think that's it for today. I'm looking forward to seeing you all again tomorrow, and thank you all for participating today.